Recently in urology clinic, I've been learning about the prostate. So you can break it up into BPH, benign prostatic hyperplasia, as well as prostate cancer. So in terms of benign prostatic hyperplasia, you can think of it as in terms of the size of the prostate. So usually average people have 30 grams of prostate, and then as you get older it gets larger, and at 60 grams that's when you can start thinking about medical management. If people start having symptoms, there's this IPSS scale that goes over questions with patients that can be boiled down pretty much into whether they have trouble urinating, like they go more frequently, their stream isn't as strong, they wake up in the middle of the night to pee, they're not able to completely pee out everything, that they have to start and stop. So when you get down into it, medical management involves a combination of tamsulosin and Flomax. And then as you get greater than 100 grams, as the quality of life decreases for people with BPH, they can start thinking about surgical management, which can involve going in and shaving off the prostate using a transurethral resection of the prostate, or you can start thinking about open procedures where you take out the prostate. And then you can get into more prostate cancer now. So prostate cancer is measured through PSA. PSA is prostate specific antigen. So there's risk factors for prostate, which include age, your race, if you're black, and then if you have certain gene mutations that can increase your risk of prostate cancer. You screen using a couple tests. The blood, that's the prostate specific antigen I was saying. You can do it through the finger exam, through doing a digital rectal exam and feeling the prostate, as well as a biopsy where you go through the rectum and biopsy the prostate. When you diagnose someone with prostate cancer, you might want to do further imaging, and that involves doing like a CT or ultrasound. Ultrasound's generally better for cancers, for prostate cancers, and CT is better for stones. PSA can be broken up into different categories, and it can be adjusted based off of age for the risk too. So less than 4, you're not very concerned about. You just want to make sure that through active surveillance, checking every 6 months or 12 months, even though this is a very controversial thing, but more information is better, that if the PSA doubles, that then you go in to do more diagnostic tests like biopsy or further imaging. This all applies for people less than 75. If you're greater than 75, your cutoff goes up. As a general rule, if your PSA is less than 2.5, you're thinking less than 10% chance of cancer. If your PSA is greater than 4, then you're thinking likely cancer, like 50%. And if it's greater than 10, you have a very, very high likelihood of cancer. When you're thinking about cancer treatments, you can do active surveillance, which is do nothing, check the PSA, check the rise, make sure that there's no metastasis. You can do this scan, which is equivalent for other cancers, which is the PET scan for other cancers, where the metastatic cancers take up glucose. For prostate, they have a different type of scan where the substrate is specific for the prostate cancer. Then you can get into radiation therapy and surgical therapy. So surgical therapy is generally recommended for people that are younger because more of the side effects and the costs are up front. So therefore you deal with the effects earlier, and then you can see how much you improve and how much function you regain. So surgery, you take out the prostate through an open or robotic approach. There's a lot of different fancy ways now. As you do the procedure, you want to find a surgeon that is really good at nerve sparing. So there's decreased adverse effects of impotence or incontinence. Surgery also allows most of your tissues to be preserved. They're not radiated, they're not wilted. So then in the future, you can do radiation, whereas you can't really go vice versa. If you do radiation first, then the surgery becomes a lot more complicated because now you have dead tissue, and that's not as clean to resect as a live tissue. Radiation therapy can be done as well. However, the effects are more long term. As you do radiation, then it damages the tissues. It kills off the cancers. However, your ability to recover from it takes longer, and you may see more declining effects even after the period where you would have seen the surgery side effects recover. So that's kind of how I think about prostate cancer.